Can you hear us? Hello, Victor here.
Yes.
Hello,
Can
hello,
you
can you hear us? Can you see us?
Yes.
Excellent. We can see you well, we can hear you well. If you speak loud, it will be good, and we can see you well.
So, yes, hello Czech Republic, hello Pardubice. Welcome from cath lab number 3 in Cluj-Napoca Heart Institute, Romania. Myself, my name is Alexandru Achim. To my left is Mihai Cocoi, my friend and my colleague. On the nursing side, we have Paula. We also have our great fellow Tudor and the anesthesiologist, Dr. Maria Bartos, she's making sure that everything goes smooth, the patient is relaxed, and we have the comfort that we need. And we also have Bogdan on the technical side. So it's a great pleasure and honor to be with you. We have a nice case, we believe. It's a full metal jacket right coronary in-stent CTO. But I think I will let Mihai show you the case, and then we will talk about our setup and so on.
Yes, so 1 second. Can you hear me? Hello, can you hear me?
Yes, we can hear you well.
Okay, so we have on the table today a 67-year-old active male, former smoker with obesity, arterial hypertension, mixed dyslipidemia, all under treatment. In his history, he had a PCI with 3 drug-eluting stents 9 years ago for an inferior ST elevation myocardial infarction. At that moment, he was single vessel disease. The first presentation to our hospital is in September this year with progressively worsening chest pain, with non-dilated left ventricle with an ejection fraction of 45% and anterior and inferior wall motion abnormalities. In September, this is his coronary angiography, and if we do a virtual dual setup shot and create a graphic based on it, we get a sense of what's really going on. So we have a circ which has some disease but nothing too spectacular. We have a significant LAD proximal stenosis followed by a CTO of mid-LAD, which fills distally through epicardial collaterals, diagonal to diagonal. And then we have 200 millimeters of in-stent CTO, which fills retrograde via septals and an epicardial from the circ and an epicardial from an acute marginal branch for the right ventricle. Now, given this anatomy and his history of drug-eluting stent failure, we went ahead and asked for a heart team. The surgeons demanded viability, and we have it. The cardiac MR shows both anterior and inferior territories as being viable. However, the patient was declined for bypass surgery due to a lack or poor distal landing zone of the mid to distal LAD. Now, given the fact that the patient was very symptomatic, we decided to stage this procedure. And in October, actually during TOBI, we did the first procedure and we fixed his left system. Being big fans of DCB therapy, we know we are in a DCB session. We wanted to do DCB only, CTO PCI. However, we did antegrade wire selection and antegrade wire crossing through. However, after predilatation, there was a flow-limiting dissection not well treated with balloon therapy only, so we needed to implant stents in the mid-LAD and proximal LAD. We did an IVUS-guided procedure, and also we checked the second septal, which is not jailed, so it's free of stents. And the LAD has a good diameter, good area, and not a lot of plaque burden. So we decided to leave it alone because this septal seems to be a good retrograde approach if we need to go retro. So at this moment, we are in this stage. We fixed his left system, and we have a 200 millimeter in-stent CTO. At least 6 years old. The stents were implanted 9 years ago, and the patient started feeling angina 6 years ago. The distal vessel is filling mainly through a big septal, which fills the PD, And also the PL feels through epicardials from the circ, which are not interventional but are good for visualization. And something what is worth mentioning, ipsilateral epicardial collaterals from a proximal RV branch, which fills the body of the CTO, which for us would hopefully be a good thing, because we believe that the CTO actually is smaller than the 200 millimeters of stents in the right coronary artery. So this is the case for today, and with this we will go back to the cath lab, and I will kindly ask Alex to talk about the setup and discuss the dual setup shots.
So I think Mihai showed you. Yeah.
Sorry?
The stents don't extend past the crux, right?
Fortunately not, but from the
ostium
LAD
up to the crux.
Yeah. So it's the same thing.
You know, typical PCI that we used to do. Yeah. That we used to do 10 years ago. So I think Mihai showed you a nice presentation. He's also an artist, so he showed you all these nice graphic images of the CTO. So you already have a grasp of what we are trying to do. Today, I think we have an indicated CTO. He's a young patient. He's very symptomatic. His EF is low. He's improving already because we did the LAD, and now we wish to give him we wish to offer him full revascularization. Just a few comments about the setup. We are biradial, right and left. Right radial, we have a 7 French AL 0.75 into the right coronary, and on the left we have a 6 French 3.5 EBU into the left main. We have a workhorse wire into the LAD for protection, and I think that's it.
And these are the dual setup shots from today. So
can we see the images?
If you can show Bogdan the angio,
show us the images.
He will put them immediately.
Perfect.
Do you see them?
Yes, we see them. Yeah.
So this is the first shot. That's standard LAO. And then we have the aerocranial setup shot. You can appreciate that the distal LAD grew, and there's a stenosis distal to the stents implanted, which we actually treated with a DCB just before going live.
Yeah, there is a new lesion distal of the LAD, but it's not very severe. It's moderate, but we were discussing to treat it or not, and while we were waiting for you and so on, we also treated the LAD. But so if you want, we can stop now and discuss a bit about the situation, strategy, and so on, and then we will show you what we did.
Okay, so we have the pleasure of having Gabriele here with us on the panel. I think he needs to leave for his plane in a couple of half an hour. So what would you do? What do you think is a challenge here? What would your plan be, Gabriele?
The challenge is that it's an in-stent CTO. So it's really unpredictable, the behavior of the gears and the guide wires inside the CTO, in-stent CTO. Sometimes it's really quick to cross the lesion with maybe with a polymeric guide wires. Sometimes you struggle a lot because the material of in-stent restenosis or in-stent CTO are very fibrotic plaque. So sometimes even if you use very stiff guide wires, for example, Conquest or Ornet or whatever you want in terms of penetration power, you get stuck because of the friction. It's not necessarily related to the hardness of the plaque, but the very high friction that you can have inside the CTO body when you have to deal with in-stent CTO. So that's the first point. The second is if they fail to cross inside the stent, it means intraplaque, the only chance that they have when you have to deal with in-stent restenosis and you are not able to cross inside the stent, is to go outside the stent to perform an external crash. That should be considered as a last bailout for sure. But they don't have any other option. For example, no option for retrograde dissection and reentry or for
ADR. Yeah.
They should try to stay inside the lesion, and if they are not able to advance the gear, the only way, even if they go retro and the retrograde gear gets stuck inside the lesion, the only way is to consider an external crash. So this is not really an easy case. It's unpredictable as well.
Okay, any other comments if you want?
I think Gabriele pretty much
okay.
highlighted
Gabriele, yes, ciao. Gabriele,
you
Gabriele has a huge experience, and he already anticipated, predicted one of our troubleshootings during the anti-grid wiring. So actually, it happened exactly like Gabriele said. Let us show you what we did.
So the first thing that we did, we tried, so we don't go for anti-grade wire escalation anymore. We go from anti-grade wire selection. And because we believed that the proximal cap actually is tough to puncture, we went with a blunt proximal cap. Yeah, exactly. We went with Gaia Next 3 and tried to puncture it. But the Gaia Next 3 seemed to advance somewhere. However, exactly how Gabriele said, the Gaia Next deflected from the proximal cap and went subintimal. This is the shot that we did only to show you that we are subintimal.
Yeah, we are extra plug outside the stent.
Extra plug. We tried to, in this case, we tried to leave it there and do parallel wire, but let's redirect. So we tried to redirect and do the Mihailo Kovacic's technique like SSTR. So we actually punctured and did a couple of holes, 360 degrees on the proximal cap. We nudged the tip of the microcatheter, which is a turnpike spiral 135, so we have all the backup in the world. And we quickly de-escalated, so this is the puncture of the proximal cap, and then we quickly de-escalated to a Gladius EX.
So we already made some holes into the proximal cap, and then
we advanced
a bit.
Please. So this was the first direction of the Gladius. The second. This was the first direction of the Gladius EX, which is definitely not good. So we were on the wrong hole.
Again, everything outside. You can even see that the wire goes around
the vessel,
the stent CTO.
So we backed everything out and then tried another hole that the Gaia did. And then
this is also a bit of coaxiality problem because the Amplatz left doesn't stay very much inside the stent. So probably from the beginning we went outside the stent. Yeah, in this case, you can leave the wire, take out the micro, trap it, and go parallel wiring and try to go on the other route. But like Mihai said, we said let's just back up and try to redirect the Gladius.
So we redirected. We even considered one of hydraulic dissections technique in order to soften the proximal cap.
You can inject a bit of contrast inside the turnpike because the turnpike is stuck inside the proximal part of the CTO, and see how it behaves. But we were not sure actually that the turnpike is not already extra plug, so that's why we didn't inject.
So we changed the hole that we poked previously.
This is another
and this is the advancement of the Gladius, which is another route. We checked in 3 or 4 projections to see that we are actually in between, so in stents.
You can appreciate already that the wire behaves a bit differently. You can see that it's grabbing tissue and it stays within the CTO.
And after that we
didn't try to knuckle proximally.
No
because the knuckle. That's a very good question actually. Is it safe to knuckle at this point, or the knuckle will just go go outside the stent and then we create a hematoma?
We tried to slide on the holes that we did, and we took advantage of the fact that we knew that the ipsilateral epicardial connection fills the body of the CTO right here, and from here the tip felt definitely more free. And
probably there is an island.
We were pretty confident that we were good. However, the
behavior of the wire, it's really promising. So
exactly,
you are having a straight tip progression, so it seems really intra-plug.
It's only sliding, no pushing, only sliding.
And it doesn't go spiral.
So at this point, the Gladius did not want to advance anymore.
We were confident that
we were good. So we had actually, this is the final position in which the Gladius did not advance. We advanced the MC.
You can see now, just a second, Mihai, because you can see now that the Gladius went somewhere, but my question is, do you feel comfortable that the
The
tip of the gladius is inside the vessel or somewhere else? Because it's not
you see
really
from here,
dancing.
the tip of the gladius
Goes somewhere else.
Probably extra
It's
plug,
not
extra
dancing
stents, I mean.
together with
Yeah.
the
Yeah.
stent.
So we
Yeah.
stopped at this position and we advanced a bit the turnpike
turnpike.
spiral. And advancing the turnpike spiral with some difficulty, but you expect that in a fibrotic in-stent CTO, there's no problem with that.
11 years, right?
We,
11 years.
we
old
redirected
CTOs.
the gladius, yeah, from another angle, and this was the progression. Yeah. So then we checked.
Good job.
Yeah, thank you. Then we checked in the retro, and you can see that at the crux, or even before the crux, there's a severe lesion. There's the PD, which is not wired yet, and we went into the PL, which is fine, no problem, because the PD feels via septal, and even if we lose it, we can recover it retrograde, so there's no problem in that. But while we were waiting, we played around and decided to also stand. So this is the exchange with the normal workhorse, the Scion, and we pre-dilated a bit the track because there was a lot of tension on the whole system, and when pre-dilated, actually the balloon got stuck on the Scion blue wire, which it usually does when you inflate like crazy, which we did.
Which kind of balloon did you inflate?
A non-compliant 2.5 balloon.
From NC track.
NC track balloon. So yeah, but it happens to all small hypotubes balloons, so it's not a problem in that. So we considered it safe not to leave only this wire to work on and to do IVUS and stuff like that, because maybe the cover of the wire might be damaged. So we did the sidecar technique. We did a retro injection to figure out where the actually PD is. And then we did.
I mean, the options here are to just work over this wire or to put a Sasuke and then wire also the PD.
And then we did the sidecar technique. We had some problem advancing there where the gladius exited, but on the same wire we put a ruptured balloon, and inside the ruptured balloon we put another workhorse wire, which in this case is a BMW, just so we don't mess them around on the table. We can recognize them based on color. And then with the BMW, we pulled back the BMW and actually tried to rewire the P.
Yeah, the wire is already a bit damaged.
It is because it was in the balloon, but yeah,
it was inside the balloon.
We can
you know,
manage.
this sidecar technique is a really cheap Pursman dual lumen.
We didn't use a Sasuke for this.
It's a really good technique, but it's a lot of trouble.
Is that your usual way of?
No.
Side branches, or?
I mean, we just had time and then.
No, we had time, so we played around with sidecar. So yeah. So then we have to.
So guys, let me do a couple of comments in the meantime while you are still working. First of all, in terms of the gears that you have chosen, that's a very interesting point. When you have to deal with in-stent restenosis, probably the best microcatheter is the turnpike spiral. And I do agree with you in this choice, because it provides you really a good support and really a good grip, especially if you are struggling to advance your microcatheter inside the CTO body, the in-stent CTO. So having such a great grip coming from the turnpike spiral, it can be really helpful during the procedure. Then in terms of guide wire choice, I do agree with you to puncture the cap with the penetration guide wire, such as Gaia third or Gaia third next. I missed this information, but it was a Gaia 3 or Gaia 3 next.
Next 3, yeah.
Gaia next 3. So it means 6 grams and very high penetration power.
Yeah.
Yes, the risk that you can carry when you puncture with this wire and you try to navigate inside the CTO lesions, in-stent CTO occlusion, is that the tip of the wire exits from the stent struts because of its high penetration power and because of its tapered tip. So as you did, once you puncture the cap, it could be better to step down with a different guide wires with less penetration power and with a flat tip, such as Gladius EX. And from the other point of view, the Gladius, and has for any other polymeric guide wires, can exit from the vessel architecture and go subintimal, has as you experienced. But then redirecting the wire, you can find the soft tissue and track the soft tissue reaching the distal cap, so reaching the distal vessel. So this is the typical strategy and gear that you should have to try up front when you have to deal with an in-stent CTO lesion.
Yes, thank you.
This was just from a technical standpoint.
What do you think, Gabriele, the Ultimate Bros 3 guide wire instead of Gladius for this particular scenario?
Yeah, that's another good guide wires for such kind of lesion. Honestly, we are talking about mid-tip load guide wires, 3 grams for Ultimate Bros 3 wires and 3 grams for the Gladius EX, but with a completely different behavior because the Ultimate Bros 3 wire is a completely hydrophilic guide wires with an uncoated tip. So it still remains the vessel architecture. Maybe it has less likelihood to go subintimal compared to the Gladius, but you can have much more friction because it's not a polymeric guide wires. It's hydrophilic guide wires with an uncoated tip. With the Gladius EX, you can easily navigate the soft tissue if you have soft tissue. But in this case, probably you had some soft tissue that you track very well. So Ultimate Bros 3 or Gladius EX is mainly related to the feedback that you can have once you advance your wire.
Okay.
Gabriele, I like to keep the procedure simple. Would you feel compelled to wire the PDA during this procedure, or would you just, once you cross into the PL branch, would you be happy to start dilating and converting into a standard case, or do you feel that the thing which colleagues did is the smart choice?
Yeah, I think that they did the right choice to try to wire also the PDA because they already create some channel with the microcatheter. So independently of the sidecar technique, maybe even just advancing the guide wires, they can follow the same pathway of the micro, reaching and wiring the PDA. I think that having both wires in both branches is the best situation because I think that this procedure will end up without any further stent implantation, but just with ballooning and DCB inside the CTO and maybe at the level of the crack. So having 2 guide wires is the best and the safest solution. You have
Yes.
two problems.
Yes.
The first one is the undersize and under expansion of the stent, and you cannot solve this with the cutting. You probably solve this with the OPN balloon as you did. Maybe you can consider IVL. The cutting is just for the fibrosis, because if you want to end up with a DCB strategy for in-stent restenosis, you have to cut the fibrosis, because with the single balloon dilatation, it's not so easy to cut the fibrosis to create some fenestration, some fissuration. So using of the cutting balloon can help you not only to improve the acute gain, but also to facilitate the drugs to enter into the vessel wall. That's the point, not for achieving a good stent expansion.
This was exactly our same strategy. So we put the OPN in, and we put the OPN intentionally on the cyan blue wire, because we knew that the cyan blue wire is we knew that the cyan wire is damaged, and we wanted to take it out anyways. So this is the OPN. I hope you can see it.
Yes, I think they can see.
Clearly.
Could you explain, Mihai, to the audience why you are considering this aspect? Why the risk that you can carry if you advance an OPN balloon over a cyan blue?
It happens especially with the cyan blue wire due to interaction of the hypotube of the non-compliant balloon with the hydrophilic coating of the cyan blue wire. And we knew that, so we OPN'd the vessel, and then of course the OPN got stuck to the cyan blue wire, and we took everything out. And then we
you can see here, this is actually, so with our strategy with the OPN is to go 0.5 millimeter lower undersized balloon. So it's a 3.0 OPN.
3.5.
3.0.
Yeah, 3.0.
It's a 3.0 OPN which we went up to 40 atmospheres. So actually you can see that this is a nice strategy and a safe one, that you can avoid perforation and you can modify the calcium. So this is the open 3.0 OPN.
And after that, we are considering to do DCB strategy on the whole vessel. But if you want to go to the other operators, maybe we can do a shot for you now. But
yeah, you can show us, because the DCB won't change the result now.
Exactly.
Radiographic, so beautiful.